on. So I'm Joe Rafferty. I'm Chief Executive of Mersey Care Mental Health and Community Health Trust, and since last March have been acting as the lead for the out of hospital cell for Cheshire and Mersey. And when I took up that role, it was really obvious to me that we were not just experiencing, of course, a pandemic, which was sort of obvious, but we were experiencing a different type of problem. We've been very comfortable operating in healthcare systems that have been largely moving themselves through the management of episodic care for a generation or so. Yet we were faced with an infectious disease and indeed a need for a population health management approach. We started to think about the need for population health management in the context of COVID, but also to think about how we've begun to connect our data differently. One of the sort of core components of a population health management approach is how we reach for data from many and different parts of the system. When we connect them together, we get different insights. And of course, the important thing is it's great to have insights, but the insights really do need to lead to decisions and actions. So our approach is called SIFA, Combined Intelligence for Population Health Action. This was about rapid intelligence gathering, really upping to a different level our analytical skills around newly connected data, making it easy to see and interpret, critically making sure that the data was widely relevant. And then really, of course, that data needed to connect across operations, across logistics. Actually, and at the end of this, I'll talk about how it potentially crosses into research as well. So for us, it was about bringing together a wide and diverse grouping. And critically, that was achieved in the 90-day deployment of the GraphNet application.
So the challenge was how we were going to pull together all that data and make it available to be used in response to COVID so quickly. So we built on what we already had. We had a shared care record solution in Cheshire and in St Helens, and we also had population health management in St Helens. And so we built on what we had and then we added in. It took massive organisation and collaboration and cooperation across all the different organisations, both clinically and technically, and with all the different IT suppliers. And it was achieved in a really short time scale and at pace because everybody worked so well together under the leadership of Joe and Jim Hughes. We quickly established what the major challenges were, which were in particular around the IG. Getting all those different GP practices and acutes to sign up was indeed in that time space a real challenge. And it was done by making sure we had the right engagement and we had clinicians helping to lead on this. And we set up formal governance from day one, having a governance board which was chaired by Joe and represented by all the different organisations as well as from the centre. We also set up our own local IG group called the Data Access and Asset Group, and they were very important in establishing which roles would have access, and everything has to go through them for approval. So technically it was a massive challenge. But because we had that great leadership and great engagement and great support and everybody from all the clinicians from all the organisations wanting to make this happen, we really pulled together and delivered it as was within a record-breaking timescale.
For us, there are a lot of actionable insights from the sort of real-time, near real-time reporting that we were able to get. There's a number of those listed on the screenshot here. But really simple stuff like COVID daily situation reports became critical to us, and to be able to have those passed around a system as wide as ours, but in agreed formats or interpretable in ways that were really right for social care or for community services or for acute colleagues. And for example, be able to understand where our LD patients in the community were, particularly as it came up to the vaccination period and so on, but also to make sure that we were providing testing into those folks' lives as well on a regular basis, and that shielding was completely effective, is a very good example of if we weren't using this sort of approach, it would have been much more complicated with many more gaps, I think, for people to fall through. The systematic, meaningful, asymptomatic repeated testing, which is smart testing, was something that we did in Liverpool, City of Liverpool, but based entirely on SIFA with lateral flow testing. So we were able to connect lateral flow PCR testing with very regular feeds from laboratory services or directly from the lateral flow sites. And that would display uptake by ward, by test site, by population characteristic, and test reason. And what's really important about that is not only that we were able to do that, and in a sense every hour, couple of hours, have a new display of where we were up to, but we were then able to use that data at the end of the day to think about the logistics, for example, of test sites. The smart testing was one of the reasons that Liverpool itself was able to reduce lockdown level for a period of time, because we were really, really agile about making sure that smart testing was doing exactly what we intended it to do. So working with University of Liverpool colleagues and other colleagues across the Northwest region, and indeed right across other ICSs in the country, we are hoping to be able to use this approach of connecting the data in the way that we have, and beginning to stand up an information flow, a set of use cases around understanding the impact of COVID and what we should do next, but based on a population of 15 to 20 million, where we can get the sort of scale and research rigor and scope that will allow epidemiological conclusions to be made, with some level of certainty. So, as a for example, we're not really clear about delayed second dose and efficacy, but the data on vaccine uptake and hospital admissions and deaths from COVID is certainly there and will contribute to an answer for that. Again, efficacy in elderly, the whole of the question around AstraZeneca vaccine and its relative efficacy in older people, which these are being resolved in ongoing ways, but to be able to collect data in a way that creates the scale, as I say, and scope for this is a real opportunity. Absolutely critical to what happens in our world next, not just in healthcare, but in saving lives, but as Ian Buchan put it, saving livelihoods as well, is to understand not just the impact on symptomology, but on transmission. So data held in SIFA on vaccine uptake, testing through whatever route, together with the load of healthcare activity data that we now have across the geographies that we could get into, can really start to answer that question. And if we're clear, scientifically clear, epidemiologically clear, that transmission can be managed in the right sort of way and so on, then that opens up, that smart opening up of society again is not just a sort of, an interest and ambition, but it's something that we can practically do using this notion of combined intelligence for population health action. And then lastly, we think about vaccination and new variants, that thing that sits off on the side, that until right across the world we've stopped high levels of infections, then we still run the risk of high levels of replication and therefore mutations that generate these variants, which may be able to escape immune surveillance. But we're in a position with the existing data collated within SIFA and the potential of expansion of that, to be able to really drive home that issue as well. So that's a pretty rapid run through of what we've done. And I hope too that, one of the things that our experience of this will do is not only say that population health analytics, but then population health management connecting into and through great decision making is something that not only helps us manage COVID differently, but actually we can start to do this with long-term conditions, with any group that we might choose to identify as a population. Thanks very much for listening.